يلا نعمك مثلا. Hello.
Hello,
Yes,
good
Dr.
evening.
Jyoti. Good- How are
Hello.
you? Hello, Dr. Jyoti. Jyoti Pratpan. How are
Yes,
you?
I'm very fine. How are you?
Fine, fine. How are you? Welcome to our meeting today.
Thank you very much.
Well,
It is 9:30 here. Now it is about
okay, we will
9:25
start.
p.m.
Okay, okay, we will start soon.
Very nice. Very nice to see all of you.
Okay, thank you. Now, you see me, I'm Dr. Anwar Al-Arhabi from Yemen. How are you? Fine?
Yes.
Yes.
Good, good, good. Yeah, we are good.
We are welcome for you to joining of a new Yemeni neurosurgery society.
Yes. My pleasure. My pleasure to always
Okay,
join
thank you.
Yemen Neurosurgery, and it's a nice platform to share some of the things what we know, and it is good. Um, lot of Indian neurosurgeons, they share, like to interact. It's very nice. Are you able to hear me?
Dr. Jyoti?
Yep.
Okay, we c- we will start now. Okay, just 1 minute.
You able to see my slides?
Yes, yes, I see it. I see it, Dr. Jyoti. I see it.
You can tell me when to start.
Okay, okay. With just 1 minute, I will introduce you, and you can start immediately.
Yep.
We will, Dr. Professor, we will start now.
Thank you. Thank you.
Welcome everybody. Okay, I will introduce you. Welcome everybody. I'm Professor Anwar Larhabi from Yemen. Welcome in Yemeni Neurosurgery Society in the Comprehensive Neuroanatomy programs, Back to the Bases modules. Today we have one of the pioneer of the neurosurgery worldwide, Professor Jyotri Berthman. He is Professor of Neurosurgery from Cavity Medical Center and Hospital and Apollo Specialized Hospital. Today he will introduce to us craniovertebral junction applied anatomy. Microphone with you, Dr. Jyotri Profman, and you are welcome with us today and next time, and we are so happy to meeting you. Okay, you can start, Dr. Jyotri.
Thank you very much. Thank you very much for all the many neurosurgeons and friends. It's my pleasure always to give some lectures and also share my thoughts. And today I'm going to speak on the craniovertebral junction anatomy, a little bit on the applied side. This is about some of the discussion points is that one is the embryology, some gross anatomy of the bony anatomy, some ligamentous anatomy functions, and few of the radiological tips, surgical anatomy, and then the surgical physiological anatomy. Now, we all know that CV junction is nothing but it is the occipital bone surrounding the foramen magnum, the foramen magnum and C1 and C2 vertebra, and the ligamentous complex as you see in this picture. The embryology of this is very amazingly interesting because this is formed by about 4 weeks' time, and it is fundamentally the basic occiput developed as a vertebra and not like other vertebrae because it forms like a vertebra of the basic occiput. It develops from the somites at about the 4th week. We have 4 occipital and 8 cervical somites in this. And as in this picture, you can see here, there's a neural tube. There are the somites on the lower sides, and this is the caudal neuropore. And these are the picture which shows the somites. Why somites are important is because these somites, they traverse to the side. They traverse to the side around the notochord, and these somites will form the dermatome and also the sclerotome. So each somite divides into a lateral dermatome, middle dermatome, and then the sclerotome. Sclerotomes comes ventral and medially and surround the notochord and the vertebral body. The fissure of von Ebner becomes the disc that between each one you can fissure of von Ebner that becomes the disc. So this is how it forms. And the embryology of CVJ is each sclerotome divides into 2 parts. One is a cranial part and the other one is a caudal part. Now, when the caudal part, these two, the cranial and the caudal part fuse, neighbor, for example, it is like that. You can see from one half from here, another half from here, and then they form the anatomy which we are going to get it. I'll come to that. Now here, the first 4 sclerotomes, they form the 3 centers. It forms the basic occiput, lateral occipital, and supraoccipital, the bones. They fuse to form the occiput and the posterior rim of the foramen magnum. The sclerotome 1 plus 2 form the basic occiput. The sclerotome 3 becomes the exooccipital centers and the jugular tubercle on the lateral side. And the sclerotome 4 is proatlas, which is very important for all of us. Now, this sclerotome 4 proatlas is very interesting because most of the congenital anomalies occur at this place. So the neural arch, you can see the neural arch is ventrally, you have the occipital condyle, anterior rim of the foramen magnum, the cruciate and alar ligaments, the neural arch. On the dorsal side, you have the lateral muscle C1, superior posterior arch of C1 here. You can see here this region. So this is sclerotome 4 proatlas. Sclerotome 4 as a proatlas. This forms tip of the odontoid, anterior aspect of foramen magnum, the condyle of the occiput, the upper aspect of the lateral mass, and the foramen magnum. So this is very important. And whenever there is a anomalies, then we form, you can see the congenital cases which comes to us very often. Now here, the fifth sclerotome, sixth sclerotome, and seventh sclerotome, then they form the further divisions down the side. So up to four sclerotomes, we are very much interested. And now if you take the C1, that is the C1 bone has got three ossification centers, one as an anterior arch, two for the posterior arch. The posterior arch fused at about 3 years' time. The posterior arch fuses with the anterior at 7 years' time. So this itself shows that in the pediatric, we find a lot of C1, congenital anomalies. And the C2 has got four ossification centers, one for the body here, one for the body, one for the dens, and two for the neural arch on the both sides. The dens has itself a two midline embryological centers which fuse at 7 months' time. So if it does not fuse, then you all know that what have this ossodontoidium, and tip of the dens at the year of 3 years, it fuses at 6 years' time. So up to 3 to 6 years, it is very crucial for all the fusions to occur at C1 and C2 as a whole. Now we come to the gross anatomy, but why we need to know about the sclerotomes and all this thing is because it is just of more of interest, but in practical purpose, you have to get the gross anatomy. This is the C1 arch. You can see here, C1 here. This is very beautiful, like a ring. You can see there is no body here. We don't have a body for C1, and there are two arches. One is an anterior arch, the other one is a posterior arch. There are two tubercles. One is the anterior tubercle, the posterior tubercle, the lateral mass, very, very thick, and you can show in later slides better about this particular bone. Then there are three facets here. One is the superior facet, the inferior facet, and one for the dens here. So this is very important, and we have two transverse foramens through which the vertebral artery traverses. So this is the atlas bone. It is like a ring one. We do not have a body here. This is very, very important. And this joint is an oncovertebral joint. This joint is an oncovertebral joint. And C1, you have, as you said, the lateral mass is the weight-bearing structure. The lateral mass is a weight-bearing structure. And as I told you, the CO, that is occipital condyle, C1, C2 facets or oncovertebral joints. So the roots are always behind it. And when we operate, we can see the roots. The roots are very, very, the moment we expose it, then we can see the roots. I'll show you a little bit later. The transverse foramen, you can see the transverse foramen. Here is the transverse foramen. And then you have a constant transverse bar there. In front of that is inferior, this is the pterygoid vein there in front, and the tip is crossed by the 11th nerve in front and the occipital. So we should be very careful. They're all important for the surgical approaches. This is why we call this as an applied anatomy. And this is the C1. You can see the superior articular facet. This is the superior articular facet, which gets connected with the occipital condyle. This superior occipital articular facet is directed medially. It is oval with a long axis. It's something like a kidney shape. Here you can see it's something like a kidney shape. They are never they are symmetrical. They are not symmetrical all the time. They articulate with the condyle of the occiput, and it is very important. It gives a flexion, extension, and the lateral rotation. It is checked by the anterior and posterior membranes in this place. So we should be understand about the superior articular facet. The inferior articular facet is directed medially. It is circular in size, while the superior one is
oval in shape. The inferior is circular in size. It's about 15 millimeter in diameter, 3.5 mm thickness in this place, and that this forms the plane of the synovial joint. This forms the synovial joint. You can see here this place, it forms the synovial joint, this one, and this is important for rotation, descent, and forward translation. So it forward translates in anteriorly. So this is the function of this particular facet joint, and it allows the head to rotation. And this is checked by the ALR ligaments. These are the ALR ligaments. You can see this ALR ligaments on the sides here. This is checked by the ALR ligament. So the inferior articular facets are very important because they articulate with the C2 facet joint. Now, the C1 facet with the dens, where this is the place. With the dens, there is a small facet joint here. It is a pivotal joint, and so it rotates there, and it is checked by the transverse ligament here. On the aspect posteriorly, you have the transverse ligament very nicely. So it is held by the transverse ligament. It rotates. So at C1 and C2, we have more rotation. This is very important and which we should understand biomechanically. As far as the C1 vertebral foramen is concerned, this is the foramen. You can see that this foramen is very wide, and this, it exists from C1 foramen, the vertebral artery exists from the foramen. The V3 part of the vertebral artery crosses over superiorly, and there is one small groove over here. This groove is about 20 millimeters from the tubercle. This is an applied anatomy which you should know this region because the vertebral arteries have got a lot of aberrations, and that I will show you in the coming slides. And then now how much of space it holds at C1. At C1, we have a lot of spinal area. You can find the spinal area is very, very large here. You can see here it is very large at this region. So about the spinal cord occupies 50% of the canal at C1. 50%. So 50% is empty and 50% is occupied by the spinal canal. The anterior posterior diameter is about 14 millimeter at C1. Now at C2, the odontoid process represents the body of C1. This place, the odontoid process, actually it is the body of C1, but connected with the body of C2 here. This is tilted actually forward. See, the body is tilted forward here, and these are the lateral masses. You can see this is the lateral mass. It's very, very thick. Here also we have three facets, superior facet, one is the inferior facet, and one for for C1. As I showed you later on, here is another facet. So this is the pedicle. This is the pedicle, you can see here. This is the lamina, and this is the pars. Superior articular process. Inferior articular process is connected by the pars. And here you can see the pedicle that traverses from the lamina, scope slides medially into the vertebral body. That is the pedicle. So you can see the direction of the pedicle is like this. The direction of the pars is like this. These are important points that we should know when we have an applied anatomy is concerned. And in this place, you can see this bifid spinous process. You have about very large muscles, RCPMs, obliques, semispinalis, multifidus, and rotators are attached here. So it is very important to preserve this in some techniques. In some techniques, we can always exercise, but in some techniques, we need to preserve these muscles. Now, the C2 vertebral body is very interesting. You can see the axis, as you know about, it is from the rotation, and it is a superior articular facet, is very, very large one. It is very close to the body. It's more anterior plane than inferior. It is again oval in shape, right? It is then again in oval in shape here. The C1, the inferior facet is round in shape. Now you can understand how much of rotation occurs at this place, C1 and C2.
the anterior-posterior diameter is more than the transverse diameter. It is convex, so it's very slippery. It is convex, it is slippery, and it is directed very laterally. It is positioned laterally, may contain part or a whole of the vertebral foramen here. It's a very small foramen, and here when there is an aberrant, it can cross anteriorly or it can go into the facet. You must be very careful. So this is the applied anatomy at this place for the superior articular facet is concerned. And bilaterally, they are asymmetrical. As far as the dens is concerned, you can see approximately it is 39 millimeters. This is the dens. This is the dens. This is 39 millimeters angled back by 16 degrees. It's angled back by 16 degrees. The tip gives attachment to the apical ligament. The back gives attachment to the ALR and the cruciate ligaments. This is what is an ALR. This is the cruciate. You can see the cruciate ligaments. All these things are attached here. So it articulate with C1 arch anteriorly here. So it forms as a pivotal joint. It's a non-weight bearing joint. It's very, very rotational joint. So you must be careful with this. And then here you can see about the vertebral artery, some important point about the vertebral artery here. And at this place at C2, you can see here, the spinal cord occupies 75% at C2, whereas it occupies only 50% at C1. So we all know that, so C1 we have more space, C2 we have less space. The C2 nerve root is anterior. You can see the C2 nerve root comes over here. So it is anterior, it's about 7.5 millimeters from the vertebral artery. So we must know about the vertebral artery. It's very important because aberrant vertebral artery may change. There will be a ganglion, which will be very interesting. I'll show you in the next pictures about the ganglion. So how they are all formed about this, the ligament structure at the CV junction is, you have an anterior and posterior longitudinal long bands. You can see these are the anterior bands, all these anterior bands, and then you have some posterior bands. So we should know about this. There are small short ligaments in between that. This is to prevent the anterior translation. You can see here this membrane of the tectorial. All these ligaments which are connected to this is to hold the very loose, highly mobile structure of the human body from the cranial to the cervical spine. And this is the very complex, you can see the ligament is complex. As I told you, always the transverse ligament is very, very important for C1 and C2 rotation. Now, there are also a lot of muscles in the posterior. Posterior, a lot of muscles which holds the C1 and C2 with the occiput. Most of them unhold it because anteriorly, we do not have strong muscles for the neck. And that is the reason that quite often the patient goes in for kyphosis. And so that is prevented by the extension pulls from the posterior muscle bulk. It's a huge muscle bulk you can see here. So this is very important. And you can say, as I told you about that this C2, this spinous process is attached by all these muscles. We call it as RCPM muscles, the rectus capitis minor, and then the major ones, and then you have the oblique ones, superior and inferior. They attach to the transverse process of C1. And then all these things are important in rotation and also hold the occiput posteriorly. And also the other important muscle is spinalis cervicis. You can see these muscles, they all hold it so that it do not fall forward. So this is very important because anteriorly, we do not have that much strong muscles at the CV junction. Biomechanically, if you see that, O and C1 joints are both bilateral here, and C1, C2 joints have the lateral and the medial rotations. You can see the complex rotation activities which are happening here at C1 and C2 joints, and also at the condyle and C1. At the condyle and C1, you have a minimal flexion, but then the more action occurs at C1 and C2. So that is very important. That is what is shown in this picture. You can see here, this is the occipital condyle. This is a C1. You have the swinging movement happens at this place, flexion and extension. So this is very, very important. For C1 and C2, more of rotation at C1 and C2. If the basic learning, if this is enough, and this is enough to understand the biomechanics of C1 and C2. And we have some radiological anatomy. Always we should know the radiological anatomy because we read the most of the thing is done by the X-rays. These are the important lines which are very, very classical: McRae, Chamberlain, and McGregor. You know, this is this yellow one, that is the McRae line, and you can see the Chamberlain line and also the McGregor. The most important point is the odontoid should not be above all these things. Now, if it is going to be, if it is above this place, then you find that it is the odontoid is migrating superiorly into the cranial cavity, which causes, compression of the medullary system, which is very, very dangerous. And also you can see here, Clivus Wackenheim's Clivus canal line. Clivus cannot. If the odontoid crosses this place, that means that it is going to compress the medullary junction. Very important here. Another important thing is about the 140 degrees of angle at the basal angle. This is very important. If you have more this basal, more than 140 degree, it become platybasia, and that also can cause a congenital involvement at cervico-medullary junction. And as far as the craniometry of anterior is concerned, there are two lines, you can say digastric lines. You can see this is the digastric line. Then you have a mastoid line here. So anything that goes superiorly, you must be very careful. That means that we are dealing with a migration of the odontoid above. So this is very important. And I come to the surgical anatomy. In the surgical anatomy, that is applied anatomy, is very, very crucial. Is you can find here the superior nuchal line here. In the occiput, there is a superior nuchal line, there is an inferior nuchal line, there is a thick part in the center. And so, why this is important for us? Because if we wanted to secure a screw at this level, we have to be below the superior nuchal line. Below the superior nuchal line, and these are the measurements. You can see the measurement. This is the foramen magnum. If you find the foramen magnum, if you go about 2 centimeters and 2 centimeters away, it is the inferior nuchal line. And then about 1 more centimeter above, you can more medially, you can place it superior nuchal line, just below the superior nuchal line. So these are the places are very, very thick as far as the occipital bone is concerned, and that can hold the screws very well. This is about CO, and this is about the condyle here. Then we can also, condyle is important because the condyle is a very thick bone. One can use the condyle for inserting a screw, but the chances of using this is very, very less. But still one can do it if it is possible to reach that area at the occipital condyle. Now, C1 is concerned, exactly the C1 is concerned, the most interesting thing is the lateral mass. The lateral mass. Now, how will you enter this lateral mass? You can see here. And this is the place. That is the middle of the lateral mass and inferior to the arch of the posterior arch. One can drill it down there and then insert a screw from the midpoint, enter it medially and superiorly, like this angle. You can see, you can see this line which is going on, and this is the C1 entry point. This is the C1 entry point. You can see here. This is a very C1, very easy to do it. It is not very difficult. I'll show you here. Now, this is the anatomy. You can see this is the head end. This is the leg end here. This is C1, C1 posterior arch, C2 spinous process, and the lamina. And here you can find the ganglion. See, after the ganglion is lifted, you find this is the lateral mass. You carefully look at the lateral mass and observe this video. And this lateral mass entered from the midline. Now you can see the midline going into the medially. Again, I'm showing this, the drill, the high-speed drill, but it's a very small drill here. And you can go from the midline superiorly and medially into the lateral mass. The screw is placed and then do the tapping. And do the tapping. This is the applied anatomy I'm showing so that the students can understand this very well after seeing the diagrams. Now you can see that, then put the screw here. This is the C1 lateral mass screw. This lateral mass screw can be placed meticulously. Similarly, one can place on the other side, but this may not be easy at all the time. I'll show you in the next slide. Now we come to the C2. In C2, you can do the pedicle screw here. This is the pedicle screw. You can see the pedicle screw placed. This pedicle screw can be placed very close or below the subfacet. Enter from here, go medially and superiorly, straight away about 20 degrees. And we can always put a very beautiful pedicle screw. So this is pedicle screw. The par screw will go like this. The par screw. This is pedicle screw, goes medially. Par screw goes like this. This is very important. I'll show you in the next picture. You can see the pedicle screw goes like that. The par screw goes like this. Now this must be very clear. I'll show you how to enter into the par screw. This is the pedicle screw point. Then I'll show you this. You can see here again. I'll show you the same thing. C1 posterior arch. C2 is a spinous process lamina here. This is well dissected. It's a lamina entry point. That is the foramen side. This is the medial aspect of the pars here. You can see here. This is the decortication point, and then go towards the superior articular process. Towards the superior articular process, drill it with care. There is no need for imaging. You can just see by eyes, you can drill it. And laterally is the foramen here. You don't need to go to the foramen because you are seeing here. You can always palpate lateral to this, and then you can and then take out the drill very carefully. So this is the par screw. I am putting the par screw here. You can see the direction of this probe which goes. This is the par screw. Now again, we are doing it because you can always go up to 10 millimeters or 12 millimeters, and then you can do the tapping similarly. Same technique from how the drill went, follow that, and then position the screw beautifully. So this is very important for applied anatomy. And why we need to know about the applied C1 and C2 applied anatomy is, if you know only the applied anatomy, we can perform a surgery. It is not just only our theoretical knowledge, but as a surgeon, we should know the applied anatomy very well, and each case must be measured accordingly. There are anomalous anatomy. I'll show you one interesting anomalous anatomy. Before that, I can tell you about it. There is a place where the medulla changes into cervical spine, and this is at the foramen magnum. We all must be aware of that. And we also should know that anomalous vertebral artery is seen in 3%. In 3%, you can have a persistent first intersegmental artery, vertebral artery, that travels between C1 and C2. Here, you can see here. You can see here. And in 1.1%, extracranial origin of the pica sometimes occur from here. So you should be very careful in this region. Always do an angiogram, CT angiogram, to see the vertebral artery. Sometimes you have a fenestrated vertebral artery. Both are normal fenestrated vertebral arteries, then unite within the spinal canal after dividing from here, as you see here. I'll show you in my case here. Now you can see this aberrant vertebral artery on one side. You see one artery come here, another branch come here. So both of them are joining inside here. So this is the place of the lateral mass. We put the screw normally in this place because the vertebral artery has got one more branch here. We cannot put it here, or you can retract this vertebral artery, mobilize the vertebral artery, and then put the screw, or you can drill through this posterior arch and then enter in. As you see that here, this is our regular entry point for C1, lateral mass. But when you have an aberrant vessel here, like in my case, we can go from here. That is through the posterior arch. Like you can see here, we have pushed it, we have pushed up, the joint space is there, and you can see this is the posterior arch here. One artery is here, one artery there. So we can push now down. You can drill it over the posterior arch, and then you do the probing, the same technique what you saw just now, and then put the screws. I hope it is very, very clear for all of you. I like to stop at this level with my applied anatomy, because further it is not needed, because it will be covered by my next speakers. And I am very grateful for giving Yemeni Neurosurgical Society for giving me this opportunity to share some of my knowledge here. So what I have now said is about something about a little bit of embryology and little bit of the anatomy of C1 and the C2, and then some important entry points at the C1 and C2, and a little bit of importance to the vertebral artery, because they are not the same. You can get the aberrant vertebral artery. Thank you very much for your kind listening. Thank you.
Thank you very much, Professor Jyoti. We have a very nice lecture, and we are so happy to listening and to see your lecture today. Anybody have any question for Professor Jyoti, please? For the for the audience, yes. Please, if there is any question, Professor Jyoti listening for you. The Dr. Ramzi Sharjabi say thank you very much for you. Thank you
Thank you.
very much from you, Professor Jyoti. We are waiting for any question, please.
Please feel free to, because this is a very beautiful, you all know that CV junction is a very complex area. Now, whatever the video I
Yeah,
showed
yeah,
is a
very
simple, straightforward case I have shown. And they are not difficult cases. We have
yes,
shown just a simple case of C1 and C2, and I have shown one aberrant vessel. And this
perfect.
itself will give us a very good knowledge how to approach. If you carefully see my video, the dissection is very clear. The dissection clear. The anatomy is seen very well. Unless you are a master surgeon, you can do whichever way. But then you have to dissect very carefully. Applied anatomy is very, very important. Whatever theory we learn, you saw my
Of course.
slides, it shows a lot of theory. But these points, all these things does not exist when we come practically. For each case is different. So applied anatomy is the most important
Yes.
thing
About this,
of all the.
any yes, any injury for the vertebral artery, it will be catastrophic result. So the dissection should be very carefully. Nobody should do blindly any fixation for this very critical area. It's mandatory to be a very clear, felt very clear anatomy, because the apparent artery, if there is any injury for him, it will be catastrophic result for the patient.
There is one question in the chat box. Can I answer for that?
Yes.
The,
Uh,
I would
uh,
I would Yeah, there is one question in the chat box. I always
Mm.
do all the cases, we do a CT angiogram. All
Pre
patients, we do CT angiography to confirm the vertebral artery anatomy when we do
Yes,
the CT
preoperative.
preoperative.
Yes, yes, yes.
Yes,
Mandatory.
mandatory. It is always good
Yes,
because
mandatory. Yes, sir.
it's very, very difficult. Once you have a CT angiograph, now what I do is I use a lot of bone models, the models, the spine models I use. We do 3D printing models, and where we can see the vertebral artery and also the bones. And so everything is planned beforehand. Before we enter into the operation theater, uh, we know everything. So when we dissect it, we know where we are going.
Of course, it's mandatory. Yeah, mandatory to know where you go, what you open.
Yeah. The main, I repeatedly, I keep telling that you must study the anatomy completely before we get into the operation. There are two important things, the vertebral artery and vertebral artery. Once you know that, you are very clear. Very, very easy to put a pedicle screw, to put a par screw in C2 and the lateral mass screws. I showed you the two different types of places. One is a regular conventional place below the posterior arch at lateral mass C1. Otherwise, you can go through the posterior arch itself if we have a split vertebral artery.
My dear professor, there is question on the chat and this chat beside. They ask if there is any vertebral artery injury. What should we do?
You see, very honestly speaking, I have not experienced it, but then if you have it, then if it is before, for example, when you are seeing and it happening, then the best thing is that you have to pack. Now I have one technique which I presented in the last complication conference, is that we use the wax, the bone wax, right? The bone wax, compress it,
Yes,
and
yes,
then
yes, right.
compress, stop, it will stop. The once you stop, you take the patient to the interventional radiology, do the conventional angiogram, that probably you can do a flow diverter or you can put a block. So it is an interventional. It's very difficult, but in some surgeons have done even the repair of the vertebral artery if it is very small. I'm talking about before you put the screw. But in case if you put the screw and you rupture the vertebral artery, better to put the screw. Don't take it away. Put the screw, tighten it.
Continuous, yeah. To
Yes,
continue.
continue. Continue.
Yes.
Yes. Don't
Yes.
take it out.
Okay. Uh, okay. There is another question, Professor. If there is, we get a right trajectory, but we failed, the lateral mass is violated. What should we should abort it with, or what we should do?
Okay, if the lateral mass is violated or it is
There is another
broken,
question.
yeah. See,
Mm. Yeah.
I want to be very honest in few things. Like, in case if the lateral mass is violated on one side, you try to purchase or at least on the other side. So that is why my approach is just very, very careful. It is in lateral mass, we cannot violate it. We have to go into the midline. I will tell you one small technique is that when we put the lateral mass, we put two small instruments like Watson Jones on either side of the lateral mass. One is a surgeon hold, the other one is the assistant hold. So you know where exactly, medial and lateral. Then you go in the midline. You will not violate. That is very important point. That means what I'm trying to
Mm.
say is the lateral mass must be visualized completely by the surgeon.
Yes. So another Dr. Muhammad Al-Namir asked if we will not do surgery, just only hollow vest, mandatory to do CT angio or no?
No, no, if it is, no, if you are not opening the surgery, then CT angio is not needed. What do you want? The CT angio is done only
No,
for surgical planning.
surgeon. Yes, yes, yes. Any other question, please? If there is any question, please write it for Professor Jute if we in the chat.
I think message has gone well. Yes.
Okay, okay. Thank you very much, Professor Jyoti. We are so happy to meeting you, and we at our pleasure to meeting you, one of our pioneer neurosurgery worldwide. Thank you very much. I will ask everybody. There is unfortunately Doctor, the Professor from Mexican apologize due to some emergency. He cannot joining us. He will joining us on the next week. Also, Dr.
Okay.
Salman, he cannot join us. We are so thank you for Dr. Jyoti and so happy for him. And thank you very much, Dr. Jyoti.
Thank you. Please come to India. We have a nice
Okay.
conferences coming. Join us.
When, Professor Jyoti?
We have next year, in the coming September, we have a big conference in my place, like in Coimbatore.
Okay.
It's very nice place. You're all welcome. I am one
Okay.
of the founder member of the Neurospinal Surgeon Association India, and please feel free to contact me. And you can join, you can share, you can involve in our conference, you can present papers, because we encourage a lot of doctors from abroad, and we have a lot of
Oh,
doctors who from Korea, particularly from Korea, England, and also from Brazil. Now they wanted to come from various parts. So I always look forward and extend my warm welcome to all the M&E neurosurgeons. Who can always please write to me,
oh, we
and please.
okay. Thank you for this generous invitation. We are so inshallah we will be with you inshallah in the next September inshallah.
Sure, coming the 25 September.
Okay, inshallah. There is a last question, Professor Juti. In case of the
Yeah.
traumatic retroclavial hematoma, what is the most common sources of the bleeding? They're asking for us.
Okay, okay. Retroclival hematoma. Okay, see, usually
Ah,
about
yeah.
basilar artery. Basilar artery.
Basilar artery. Yeah.
Yeah.
Thank you very
Usually.
much, Doctor.
Thank you. See you all.
Uh,
Good night.
no, see you.
Good night.
Thank you very much, Doctor.
Thank you
Thank you for
very much.
everybody joining us that's this night. We are we are so happy to meeting with you, everybody. Unfortunately, we cannot continue another speaker due to some problem. He cannot join us. They will joining us the next week. Thank you for you us and thank you for Professor Judy, and thank you very much. We will end the session now, please. Thank you.
Thank you very much. Thank you. Bye. Bye.